which is presented by Job van der Heijden, and it's about what we can learn from wound care in dermatology. Please, Rob.
Thank you for inviting me. I'm Job van der Heijden. I work as head of research and development at KSYOS Telemedical Center, which I will tell you a little bit about later on. And I have a PhD in telemedicine evaluation research, which I work on with PhD students at the academic hospital in Amsterdam. So eHealth, yeah, it's being pushed forward. European Union has put out eHealth Action Plan 2012 to 2020, and in the Netherlands we have the National Agenda for eHealth Implementation. So we have a push, and I will tell you a little bit about the success story we have with TeleDermatology in the Netherlands. But first I would like to share a little anecdote with you about my dad. My dad recently had an acute inflammation in his left arm, and after a brief telephone conversation with the GP, he had to go to the emergency room where he was admitted. He had to receive emergency acute operation surgery, and then he was released that night. But the next day he had to go in again because the penicillin wasn't taking effect, and he had to go through the emergency room again. So by that time he had seen about 4 nurses and 6 physicians who were all typing in their information and all the answers he provided to them, because all the Netherlands hospitals nowadays have electronic patient records. So after 2 weeks he went in for a checkup to the 7th doctor. Didn't see this doctor yet. And this doctor, the first thing he asked was, what kind of medication do you use? And my dad, being fed up with the 7th time he was asked this question, asked the doctor, you are behind your screen, why don't you look at it? It should be right there. On which the doctor answered, there's too much in there, I'd rather just ask you. So the point I'm trying to make is, because we're all pushing this, we sometimes forget that it's persons. It's both patients and the physicians, everybody using these technologies. It's persons, and we need to think about this when implementing. So I'll skip some of the parts that we already discussed here about costs. This is funny to show you a little bit. This presents yearly cost in the Netherlands compared to the cost for healthcare. So 5 hours of care can be paid by the yearly amount we spend on our royal house. 1 month of police, of 1 month of care is a yearly cost of police. 2 months of care is the yearly cost of primary care. So the cost expenditures are huge in the Netherlands. Promises of telemedicine, we've heard them all today. Again, the types of classifications, the types of different definitions we use, they're all there. We can talk about it for hours, but in the end it all comes down to one thing, which is healthcare. It's healthcare like we did it, like we have done for a couple of decades, but now we're using all these new technologies that are being made available to us, mostly also through commercial companies. So everybody can book a flight online. Everybody uses all these different technologies in their life for tax registration, for banking, for locating yourself, moving yourself around. So we should basically, the GP takes a picture of the patient's condition and takes the pictures and sends it to the dermatologist, who can respond with an advice and a diagnostic back to the GP and integrates it in the GP information system. When you look at it on a broader scale, TeleDermatology and onwards it has shown a steady output of clinical research. If you look in PubMed right now, you can see that when you type in tele-dermatology, it already gives all these different subfields. So the scientific base is steadily growing. Looking at the review articles, we can say that tele-dermatology has a diagnostic accuracy and reliability dependent on what setting is used and what type of healthcare economic systems are used in these settings. So if you look at also what is being published, and it was mentioned before also, that it's mainly pilot studies. There's no real integration in the national health system or in a regional health system that has tele-dermatology completely integrated. But we do know that the clinical outcomes are similar as well, and when you look at the quality of life perceived, you can see also that this is similar to the conventional care we provide. So I'll give you an update on my PhD research that we did in the Netherlands on the full integration of tele-dermatology in our national healthcare system. A little bit about the Netherlands, smallest country we've covered here this morning. 60 million inhabitants. We have a high density of population. As you can see, it's mainly focused about in the urban Amsterdam and Rotterdam areas. We have about 350 dermatologists in the Netherlands, which comes down to 1 dermatologist per 45,000 people. Also, we have about 1.2 bikes in the Netherlands per person, which results in an Amsterdam picture like this. So, of course, we have the same population, aging, and problems that come with that. And when we look at the tele-dermatology right now, so these are updated results as of last week, we have about 3,000 general practitioners using tele-dermatology, which is about 40% of the GPs, and we have about 253 dermatologists using it. And today we have had about 100,000 tele-dermatology consultations being performed in the Netherlands. So you can see that once we started, we had our pilot phases in 2001 till 2005, and in 2005 we really were integrated into the health system. We had a steady rise in the number of teleconsultations per year. We've looked at what types of diagnoses are being sent in by the GPs. Mostly are eczemas, but you can see there's a broad variety of diagnoses being sent in for teleconsultation, and also some streamlined tumors are being sent in. This is also on the rise because a lot of GPs are now using dermoscopy add-ons for their cameras, and our dermatologists are being trained as well in how to assess these dermoscopy images through teleconsultation. So when you look at the response times of the dermatologist, we urge them to respond within 2 working days, but you can see that almost all teleconsultations are answered within 1 day already, and I think the average we have now is 5 working hours for a response. So the patient who comes into the GP session in the morning will be called by the GP assistant later on in the day to receive either a treatment or medication advice, as compared to maybe waiting 2 to 3 weeks to go to your dermatologist. If you look at when these teleconsultations are being sent in and answered, you can see there are spikes around the morning hours, around lunch hours, and at the end of the day. But you can see also there are some diehards that answer teleconsultations in the middle of the night. So why does the GP in the Netherlands do tele-dermatology? Well, there's two types that we can distinguish. There is the referral prevention, so a GP wants to refer this patient but uses tele-dermatology to see if it's necessary. And also the technology enables him to use tele-dermatology for advice. So he might not have referred this patient if tele-dermatology was not available, but now he uses it because he can get advice pretty fast from a specialist. Of course, that second option is raising costs. But you can see later on that it's still a cost saving because of this main group of referral prevention. So in this first group, about 73% does not have to go to the hospital after teleconsultation, which is a huge number, obviously. But now they are diagnosed on an early stage and see the specialist because they need to. If you take into account the whole population, you end up with a total prevention rate, again, of 68%, so still a big number. And we also implemented some evaluation questions in our system in which we asked if the GP has learned from the system and if it's useful. And as you can see, most of them tend to have a feeling that it's been useful to them to use as a tool in their practices. If you look at the costs, in the Netherlands we have a diagnostic treatment combination tariff that is linked to all these different diagnoses. So the diagnosis that we've categorized earlier, that I showed you earlier, we have calculated a weighted average based on all the percentages, what a patient would cost if he would have gone to the hospital. And that boils down to nearly 200 euros. And the tele-dermatology consultation is around about 68 euros. Both tariffs are slightly different based on what type of healthcare insurance company you're using. But in the Netherlands, we have about five main ones, and they're all around these numbers. So if you use the percentages that I showed you earlier and put them in this formula together with the tariffs, you come down to the average price of 155 or 57 per patient in the total population where tele-dermatology is used. So that comes down to 18% cost saving compared to the 192 if tele-dermatology was not used. We also wanted to see if there is a trend in the use of tele-dermatology and the referrals to the dermatologist. So we looked into these are small numbers, all preliminary as the study is still going, but the first signs are that GP practices with tele-dermatology, which is the blue line, tend to refer less and then even go down in their referrals, as the red line, which is the GPs that do not use tele-dermatology, tend to refer even more and more and more. And the red line is coherent with the national increase of referrals to the secondary care. And if you also look at the tele-dermatology consultations used with the blue line, they also go down. So the GPs refer less, and they also use tele-dermatology less, which leads us to believe that because they are using tele-dermatology for 5 years already, they have learned from seeing these pictures time and time again, together with the answers provided by the dermatologist, that after maybe 10 times they can diagnose these patients themselves and not have the need for a specialist anymore. So there's some cutoff point. At some point we'll see a stop in the rising of use of tele-dermatology, and we might even see a decline at some point. But still, it's there to be used, and with the rise of teledermoscopy, this is a new whole area that we're entering into. So what were the challenges that we're facing? It's obtaining the reimbursement. It's much said by many speakers here already. Resolving technical issues, communicating with the referring provider, setting up TD operation, which is interesting, and setting up education programs for all the staff to how to use it. But the success factors that we have used and implemented in the Netherlands are a very regional approach. So we had our GPs communicate with a regional dermatologist to which they already had a connection because they were referring their patients to them as well, so they know each other. We have negotiated sustainable reimbursement, so we have made a business model with all the stakeholders, mainly, of course, the health insurance companies. And we have used a whole approach, holistic approach, to perform research and to provide quality indicators so that we can actually show all the stakeholders that it's being used in a good way, and we're making a success of it. So the strategy that we have implemented is to use a dedicated telemedicine provider, which is, in this case, KSYOS in the Netherlands. As I said, we were founded in 2001 as a research institute. In 2005, we became an actual healthcare institution. So KSYOS is similar to any other hospital in the Netherlands. We are responsible for developing, researching, and implementing telemedicine services. And all these services, we negotiate contracts with all the healthcare insurance companies to make sure that we have sustainable business models to provide these services. So right now we have about 7,000 GPs working with us, which is about 90% of the GPs in the Netherlands. And we have a lot of medical specialists and paramedics in different fields as well. Right now we have about 200,000 teleconsultations, 250,000 tele-diagnostics or tele-examinations. So ECGs, respiratory signs, fundus, pictures of the eye for diabetics, all types of measurements. And we do this in all these different types of fields. So the main ones, dermatology, ophthalmology, cardiology, pulmonology, but also nephrology, ENT, radiology, you can name it. So our goal is to provide faster, better care, closer to the patient at lower costs. And I think, to close off, is that as a telemedicine provider, or anyone who is providing telemedicine services, they should try and implement all these things. So you want to do the administration, registration, storage of clinical records, negotiate the tariffs, you want to do handling the claiming, crediting, reimbursement of all the actors who are involved. We have a liability insurance specified to telemedicine. You need a software platform, so electronic medical record that it's used. You need to provide hardware and make sure that it's certified. Provide education, if possible, accredited in your country by CME credits. Provide some project management for regional implementation of these services. 1-hour training sessions for all the actors to get to know the system, have a help desk service so people using telemedicine can contact someone to help them with it. Have yearly reports to all your stakeholders to show that what you're doing is going well, and if it's not going well, make sure how to show how to improve it. Provide integration with all the different systems that are being used in the country, and try to adhere to the standards as best as possible. I know this is a lot, and I'm not saying that we are there yet, but we're trying to take all these points into consideration. Thank you.
Thank you very much, Rob, for presenting these data from Holland. Any questions? We have time for 1 or 2 small questions. Over here. No, there.
Thank you very much for your presentation. Do you have any programs that go directly to the patient in the home, and even do you see the tele-dermatology program being extended out directly to the patient in the home, perhaps for follow-up?
Mm-hmm. Yeah, well, right now we have a law stating that for a patient-doctor relationship to start, and also to start a diagnostic treatment combination tariff, which is needed for reimbursement, you need to have the first face-to-face contact. This law is being retracted next year, so then we'll probably see a lot more of this patient-doctor telemedicine, but we have focused mainly on doctor-to-doctor communication. We do have implemented a pilot in telewound care also, where the first contact is in the hospital and then follow-up is being done by a nurse, a wound nurse in the home, and takes pictures and sends it to the dermatologist. On this such a large scale, there's not any patient-doctor telemedicine going on, but there's many pilots already, and we'll have to see how that pans out if it goes to a fully integrated service.
One more question from over here.
Thank you for a nice presentation. That was actually my question. Do you have any experience with the wound care and telemedicine?
Yeah. So as I said, we have a small pilot going on, which is seeming to go well, but it's more difficult to get a business case going for that, which has to do with different tariff sections. These are mainly, our tariffs mainly are in the second line, and the wound care is more cross also in the primary care, which is a different system. But the results on prevention are looking to be similar to what we see here. So patients are less referred to the dermatologist. So instead of going for a monthly checkup or bi-monthly checkup, they can go maybe every 3 months.
Could I just ask one final question, Rob? There's one point I'd like you to address. What about the patient safety? I mean, you said that you sort of educate the GPs and you have a reduction in the number of admitted patients. Mm-hmm. Do you think there is a risk that they might oversee something because they feel like dermatologists, or they don't really see the skin cancer coming up or something like that?
Well, I mean, there's definitely a difference in skin cancers and melanomas compared to eczemas and all these more non-fatal dermatological problems. We've heard those arguments time and time again. Every time we go into a new specialty, 50% of the doctors are opposed, saying that they will miss something. 50% are saying, we'll do it, we'll try it, let's do research and see if we can actually make it happen. Based on the research from the past decade from all over the world, I'll say in dermatology there's definitely, because it's such a visual-based specialty, they can definitely make a diagnosis based on the pictures. It's a responsibility of the GP also to assess if a patient is suitable for telemedical treatment. And you have to do everything you can to make it as safe as possible, similar to any surgery that is going on, similar to any treatment in any hospital that is going on. But you do have to, and if research shows that it's actually for certain types of diagnosis viable to use telemedicine, then it's up to the users to decide if they want to.
Maybe next year you can come and present in London how many biopsies you perform, if there's a reduction in the number of biopsies, because the GPs sort of handle things. But let's leave it at that. It's fine. Thanks a lot.
Yeah, thank you.
And this concludes this session. On behalf of my co-chairman, Catherine, I would like to thank you for attending this session.